Please welcome Justin B. Smith, co-founder and CEO of Semafor.
Good morning, everybody. Please, those of you in the back, please come in. I think there might be some more seats up here. Good morning, and welcome to Semafor's inaugural The Future of Health Forum. I'm Justin Smith. I'm the co-founder and CEO of Semafor, and along with our partner company Gallup, where, of course, we're in the Gallup building, the Gallup Great Hall, where Semafor does a lot of our convening with Gallup. We're thrilled to have you all with us here this morning. When we launched Semafor 3 years ago, we set out to make sense of a world that's more polarized, complex, and interconnected than ever before. And in 3 years, we've built a global news and intelligence platform built for what we call the new world economy, designed for the people who are leading it. So we aim to provide our audiences of global leaders with very sophisticated insight and diverse perspectives by building a new model. In fact, bias and polarization in the global news media landscape was our singular innovation mission when we started the company. And hopefully, if you subscribe and read just some of our products, you'll see how we're attacking that head on. We're also an events-first brand, a convening-first company, powered by a lot of our substantive journalism, and gatherings like today are largely emanating from our newsroom, which is a big differentiator. This morning, we'll hear from those at the forefront of one of today's greatest policy challenges, ensuring affordable quality health care in America, and powered by brand new data from our friends and partners at West Health and Gallup. Today's conversations will shed new light on how Americans feel about the care they receive and where leaders across public policy and healthcare are seeking new solutions. So before we begin, I want to thank our partners. All of us at Semafor are deeply grateful to West Health, as well as Gallup, for supporting today's live journalism here in the Gallup Great Hall. Thank you for spending this morning with us. And now let's get to the news. Thank you so much.
Welcome Jonathan Birks, Executive Vice President of Economic and Health Policy for the Bipartisan Policy Center. Andrew Friedson, Health Economist for the Milken Institute. Tim Lash, President of West Health. And Amna Nawaz, co-host of PBS NewsHour.
Good morning, everyone. Thank you so much for being here. Good morning to all of you as well. We're going to jump right in and talk about this new Gallup West Health report. And Tim, I'm going to begin with you.
Sure.
Heard a little bit about it from Justin there, but just what was your takeaway, your biggest takeaway when you saw the results of this report? What stands out to you?
You know, I think it really is a tale of two cities in many ways. So the bright spot is there is separation between the states. And that tells us that there are interventions, there are investments that communities can make, that states can make, that our country can make, that make a difference in terms of affordability, in terms of access, in terms of the outcomes that we get. But I think what's really concerning is that, when you look at the top 10 states, as it relates to, difficult choices, can you afford your health care or are you foregoing care? 1 in 5, right, in the top 10 states are foregoing the care that they need. If you look at the bottom 10, that approaches nearly 50%. And so really we have the top 10 states standing on the shoulders of the bottom 10, right? It's not a really great place to be. And not to be provocative with this, but you could also do a survey and ask what's the best cancer to have, right? And I'm sure we could come up with a list of cancers where one is slightly better than the other. But I hope we would all agree no one wants to have cancer, right? And so even in in the top 10, it's unacceptable, in this country that this is what we're facing. But I think the brightest spot is this survey really provides a roadmap for us to move forward, right, and to think about where policy can actually meet what the lived experience, the expectations, and the pain points are of families, of communities, of states. And I think that really needs to be the North Star of policy and the system reform that we need.
Well, Jonathan, let's talk about that policy then. When you look at the results of this report, one number stood out to me. Only 9% of Americans grade the health care in the area of overall as an A. Only 9%, meaning excellent, giving it an A. The most common grades were a B, which is good, at 33%, and C at satisfactory at 37%. What's your reaction to that, and where is the policy lever that could start to change that?
Yeah, thank you. I think one of the things that really struck me about that finding, it really does speak to the moment where people aren't satisfied with what we have. The system isn't working the way that anyone would like it to, and so we can do better. And I also take sort of solace from the reality that of the top 10 states and the bottom 10, that there's a diversity of red, blue, and purple states in there. Mm-hmm. And so it's not that there's a single set of policies that are going to be the solution in each community. It really is that healthcare is a very localized experience. And so people have to have a set of policies that work in the communities that they're in, as opposed to sort of there being necessarily a one-size-fits-all kind of solution.
Is there any policy through line to the states that are doing better than others?
Well, I think it's a commitment to healthier lifestyles in a lot of ways. There's a sort of, and it's comprehensive. So it's not just a matter of, well, we've got a more generous set of financial incentives to be insured necessarily. That's one of the things that can help, mm-hmm. but also things like the culture of the state in terms of whether it's sort of urban versus rural, indoor versus outdoor sort of oriented. These are all things that matter, mm-hmm.
And
so the complex web of what makes a community has a lot of the impact of how they feel about healthcare and how they feel about their health in general.
And just to add something to that, one of the reasons that we stood up the West Health Gallup Center on Healthcare is that obviously these are perceptions, right, around their experience, and I think that needs to be a durable commitment to understanding that and having that as the foundation. But you also need the infrastructure to be able to interrogate that, yes. to make the links between what some of the investments that are made or the policies and how that translates into the expectations and actual experiences, and I think that's something that has been missing, but that is absolutely necessary as we move forward.
Yeah, and I think the fact that you're looking at it state by state is really important as well.
What about the connection, Andrew, between the moment that we're in, and specifically around concerns around people's finances and the economics? There's another figure that stood out to me where the cost of healthcare evaluations were much more negative than the overall ratings. The largest group at 42% gave it a D rating, which meant poor. Only 2% graded the cost of healthcare in their area as excellent.
So to start off, I just want to, full disclosure, I no longer work for the Milken Institute. I started at the American Society of Anesthesiologists yesterday, but I'll speak today as former economics professor and textbook author on health economics.
Congratulations on your new role, we should
thank
say.
you very much. I don't view any of the grades in this report as good. When I was a professor, if my best grades were B's or C's, I would be really, really disappointed with how this class is performing. I've got some states that are doing bad and some states that are doing very, very bad. When you're looking at the cost thing, this is the part that just jumps off the page at you. This is the youngest part of the population and the lowest income part of the population. The numbers are double or in some cases triple when they're saying they don't feel like they can afford things or they're taking on debt to be able to afford things. And this is for the people that are actually engaging. If you look at a different data source, the Burfus, which has about 400,000 participants, then you can see about 18% of people in this same age category, they don't have any contact in the past year with the healthcare system at all. So they aren't necessarily going to be people who are saying, I can't afford this or I'm taking on debt. They aren't engaging with it one bit. So it's even larger. Keep in mind that this survey is going to be an underestimate of how many people are going to be having a negative cost experience, because some people just don't engage in the transaction at all. My point of view, or my read of the results, is that this is very much a question about the value proposition of healthcare in a moment where there are a lot of other things that people cannot afford. They cannot afford to put food on the table. They cannot afford their rent. They cannot afford, childcare. And when you have a bunch of things that are immediate and you are younger and are less likely to have a health problem, then spending the additional money on health insurance is going to be a bad value proposition until the lightning bolt hits you and you have the bad health event, and then you're financially wrecked. And I think one of the things that we have a big problem in this country, and that we have a big problem with anywhere you have a free market for purchasing into health insurance, is making the value proposition to the younger, healthier population. This is the same story we've been telling for the last 20 years.
Just to put I agree with everything that you said, but I think when we think about cost, often we think about that in isolation from outcomes, right? And what I mean by that is if any of us go to the doctor and they prescribe a medication and you had a side effect of that medication, we would say that's a clinical outcome, right? You had a side effect, adverse event, right? But there's a toxicity that co-travels with cost, right? And so if you're skipping your medication and your health deteriorates because you can't afford it, right? That's not just a trade-off of your vacation or your rent, which is and unacceptable as well. But it translates into poorer health outcomes, right? And if you look at the Medicare population in the United States, there's about 125,000 lives that are lost every single year due to non-adherence, due to cost, right? Lots of reasons why people don't take their medication. If you just try to isolate that on cost, right? And so, think about, the campaign in Vietnam, north of 50,000, American soldiers, sort of lost, right, over a decade, right? And we have 125,000, Americans every single year, right, that are losing their life because they can't afford the medication that they're taking, right? So they don't take it, right? And so it's not just, the toxicity isn't just, on the pocketbook, right? It actually translates into stress, right, which, has worse outcomes, from a health perspective, and in some cases co-travels with a much higher mortality.
I mean, Jonathan, there's obviously so many links between all of these issues, right? The Venn diagrams are very complicated when you start to lay them out, but this issue too of a generational difference, that younger Americans are looking at this differently. What does that mean from a policy perspective?
Yeah, I mean, I think at this moment when the healthcare conversation is so dominated by what is the future of the enhanced ACA subsidies, it really does get down to sort of this differential valuation of healthcare. I think Tim's exactly right that there are sort of all of these additional costs that are sort of harder to identify sort of the impact, but they're real, but they're harder to identify in real time. And, I think what Andrew was saying in terms of individuals not necessarily valuing or recognizing the value of being insured is one of the things that we're seeing in the current debate, where the marginal cost of maintaining sort of current levels of coverage under these ACA subsidies is so high for a relatively small population, in part because for them the cost of acquiring insurance is just not, they don't see the value. And so part of what I think we in sort of health policy need to do is, as we work to improve the affordability of the system, we also have to make the case to individuals about why there's value in them participating in the system a priori, as opposed to waiting for that health event.
Tim, it's impossible to not look at the current context we're in right now, and also to point out the survey was carried out before the government shutdown, before the fight over the extension of the ACA subsidies. If these questions were asked of people now, do you feel like the answers would be different?
One thing that we found, right, as we've sort of tracked the perception of healthcare, and Gallup has done this for decades, but through our partnership, is that in just about every measure, we're deteriorating. But also, I think there's an awakening, right, in that, the healthcare in the United States perhaps does not yield the best outcomes in the world. And so if you go back just, 6-7 years and you ask people around their own healthcare experience, and I think part of this is because it is so expensive, right? It's uncomfortable to say I'm paying a lot and I'm not getting a lot, right? And so, historically people reported that, like, whether their own healthcare or the perception of the system, quite high, right? And what we've seen through COVID and through, economic sort of challenges, and I think just an awakening awakening of, perhaps we're not getting what we're paying for, is that, Americans are quite dissatisfied with, the results that they're getting. And I think objectively that's the case. If you look at how the U.S. performs against other OECD countries or, the most developed countries, nations in the world, we rank number one on cost, and at the bottom on every, objective measure, including things like life expectancy and infant mortality. So I think it's getting worse, for sure. And we're sitting here today, European markets are crashing, right? I mean, there's a little crypto crash that's, mini crypto crash that's happening. But the healthcare prices, right, are still, continuing to rise at a very steady clip. And so I think that's a real call to action, right? Because I think, I know it would be worse today, and we'll do that work. But it's eroding, and that trajectory has to be corrected.
Andrew, I know you've already said, as a professor, B's and C's unacceptable. You're not happy with them. I get it. But when you look at the overall reactions here, overall healthcare ratings low, cost of healthcare ratings even lower. Quality of healthcare, though, did receive slightly more positive ratings than cost. Most people gave it a B or a C, about 35% for both of those. So there is room for improvement.
The
but how do you look at
American
that?
system has the best healthcare in the world for the people that can afford to pay for the best healthcare in the world. We have it's not just a question of being able to afford to pay for it, it's also a question of for the people that can get time off to go use it, for the people that can get to it. Rural communities, for example, are extremely isolated from a lot of the best care. So we have a system where we innovate more than anyone else in the world. We provide the highest quality care in specific places relative to everybody else in the world, but it's not accessible to the largest part of the population. And so when we're looking at our perceptions of quality, yeah, we can see absolute medical miracles that are happening in this country. When it comes to the ability for your average American or below average in respect to income or with respect to insurance coverage American to be able to access these things, it's not, that's where you're going to have some great inflation.
Jonathan, you were going to jump in earlier.
Well, I'm just going to make the point that one of the fundamental challenges of American healthcare is that ultimately what all of us are interested in is health. But of course, you can't go to the store and buy health. And so instead, you're thinking, well, medical services, that'll help me maintain health. So how do I go out and buy those? Well, that's really hard to do as an individual in the United States. The prices are non-transparent. The system isn't set up for you as a consumer to go out and go get medical care directly. And so instead, you go buy insurance. And so you're sort of 2 steps removed, at least, from sort of what your ultimate goal is. And so making the value proposition that buying this insurance product is going to lead to ultimately me getting the outcome I'm actually most interested in, which is health, has become more and more of a challenge as prices rise, as the system seems unfair, as there are challenges in terms of access, as there are challenges in terms of sort of instability in public policy around how to get there and the complexity of it all. And so, I think one of the core challenges as policymakers is to think about how do we make the system simpler? How do we make the connection between sort of what the consumer is actually able to purchase, this insurance product, and the thing they're actually looking for, health, more clear? And doing that in a way that seems fair and seems consistent over time is just a fundamental challenge that we'll have to tackle.
You're talking about making the insurance system simpler
Well,
for
the
people
whole
to
healthcare
engage with?
system, honestly. I mean, because insurance is one piece of that.
Yeah.
And obviously there's a ton of challenges that come with accessing the insurance system, whether it's prior authorization, networks, all the rest. But ultimately, again, what the individual is interested in is their health.
Yeah. And
how do I promote that? And so if we're going to maintain a system, and I think we are, that is reliant on sort of these intermediate steps, then you've got to make sure that the system overall is as transparent as possible so that people are able to see these connections and able to have confidence that they're getting value when they...
And that's a really great point. I think there's a real tension between I'll just say the culture, dynamics within our healthcare system, right, and the profit model, right, and what people are paying for with health, right. And so in the United States and in many developed countries, we've taken bleeding edge innovation, whether that's on drugs or devices, right, and put that on a pedestal as if that's, sort of the ultimate answer, right. And lots of sort of reasons for that, right. It's I think it's sexy and it's very profitable. Maintaining that status quo, whether you're a hospital or a pharmaceutical company or a device company, right. I mean, you can just look at the market capitalizations, right, of these companies over time. It returns significant shareholder value. It does not necessarily return health, right? And so when we think about what has to happen to drive towards that, right? It's part of its insurance reform, but we need to think about also retooling the system so that we can have better access to primary care. We can have better access to that you can maintain the health and prevent the decline, right? Sort of as we age. And so I think it's a fundamental systemic shift and cultural shift in terms of how we approach it.
Yeah, you want big returns on investment with regards to what you're spending and what you're getting out with respect to health as opposed to healthcare utilization. Your biggest return on investment are going to be prevention measures and lifestyle choices. Right? I've got a medical device on right now. It just counts my number of steps and tells me to go on a run, and that's going to make a tremendous impact on my health, and it's tremendously low cost. I'm not saying that the answer is everybody needs to just be exercising more, but what I am saying is that there are systematic lifestyle nudges that we can be making that are going to have a much larger population health improvement than innovating a new, better surgical robot. I'm not saying that we shouldn't do both. I'm just saying that we need to be thinking about, look, I'm the economist, right? You need to be thinking about what you spend versus what you get.
So what does that look like on a molecular, actionable level? We've talked a lot about, the survey is so interesting because it does go state by state, but is there a federal policy, a federal incentive that should be going into place to nudge those kinds of lifestyle changes, to prioritize prevention? Have you seen what you want to see from this administration or past in the way of these are good steps to be able to take right now?
I think this administration, particularly with respect to CMS, they've been very open to the idea that you can spend a little bit on prevention and save money down the road. And I think that that's one of the areas where there's a lot of room to improve. And by room to improve, I don't mean like, we're all doing that. But it's, I think that this is where we can actually make some tracks. There are things such as, some of the stuff I've been working on at Milken before I left is community health workers, for example. They're very effective at getting people connected to the proper levels of preventative care. They are cost effective. They're just very hard to track the cost effectiveness because prevention, you don't see the dollars that aren't spent. And so coming up with more clever ways to build out your data infrastructure so that you're able to track when prevention actually prevents is, in my mind, one of the places where there's low-hanging fruit for improving the healthcare system.
I think there's also opportunity potentially in nutrition. It's obviously an area where the administration has expressed interest. We'll see what the actual policies look like, but building in or getting more of a focus in the industry writ large in terms of producing healthier options, I think is one of those things that, again, it may be marginal effects, but at the end of the day, that's what you're able to push on.
I agree with that, but you have to follow the dollars, right? And in the current system, fee for service, still, predominantly, on value-based care, which is, I think, a buzzword. We've taken a journey, we've gotten lost, and I think in many ways we're completely disoriented in terms of what that means, right? But at its core, we have to align, right, how we pay for healthcare for the health outcomes that we want, right? And until we, put dollars at risk, where if people are healthier, the health systems perform better, right? And if people are sicker, right, they're not achieving their health via nutrition or prevention or other things, they perform worse. We're going to be stuck, right, in a status quo. We're doing more, right, more interventions, more drugs, et cetera, more procedures, right, is profitable, and you just turn up the pace of the treadmill, and that's what we've seen, right? And so I think we have to, core of this is making sure that our payment models, right, are aligned with the actual outcomes that, that are possible, which is health, like better health, and with the outcomes and priorities that we're finding in these surveys, like that address the pain points, the perceptions, the realities, right, of the families, the communities, and the states.
So can I ask, what about lowering the cost and making more accessible GLP-1s? Which is what the president held a big event in the Oval Office to announce. It is a priority. There's a preventative angle to it. What's your take?
I think it's a positive in terms of greater access. I mean, obesity obviously is a condition that has a lot of negative health outcomes associated with it, and so increasing access is a positive in general. I think there's broader questions to be asked about whether sort of the direct-to-consumer models that sort of are at the heart of the administration's engagement in the pharma sector, whether those are the solution, quote unquote, to affordability in pharma, and I think the jury's still out on that.
Andrew, you made a point earlier when we were speaking about the connection between health longevity and financial longevity. When you pull us back from this sort of step-by-step conversation, what's the bigger picture we need to keep in mind when we have these conversations about health cost and outcomes?
I think the big picture that we need to keep in mind is that we're looking to give people healthy years where they can afford to live a life that they're going to be happy with. At the end of the day, people want to go out and they want to buy health. You can't go out and buy that directly. At the end of the day, people want to go out, they want to buy time with their kids, they want to buy time where they're functional, they want to buy time where they can do the things that enrich us. And I think that's kind of where we've lost our way a little bit, is that we're thinking about the healthcare system in terms of dollars we're spending and how many lives we're saving, or dollars we're spending and how many people we're moving through the system. And I think that instead of thinking about quality of care, we need to be thinking more about quality of patient life, and that will allow us to get into more of these upstream types of things, such as dealing with environmental hazards, for example, or dealing with nutrition. I think these are all the types of things that have not been part of the healthcare systems because we've been using the system very tactically of we have a problem and we're going to attack it here, as opposed to strategically saying we've got a problem and we can nip it up here before it starts growing out of control.
Yeah, I mean, it reminds me of something I read years ago at this point about sort of what is the highest value sort of public health interventions that we've made. Clean water, reduced air pollution, and sort of having a food safety system that has reduced foodborne illness. Three highest value things that, frankly, none of us really talk about in the healthcare space much anymore. And we ought to be thinking more upstream.
No, agree. And you mentioned GLPs, and I think I just want to circle back around to that because it's very topical right now. As we think and 100% aligned on, we need to be thinking about the health and what people are actually playing for, right?
Yeah.
Being able to go to the wedding or like engage with their children, right? Engage with the community. But we have to do that in a economically and financially stable way, right? And sustainable way at the level of the individual and the family, and also at the level of our total national health expenditure. So for GLPs, right, we're facing a world today where the rate of prediabetes and obesity, really, even in the adolescent population, is going through the roof. I think it's approaching 30% in some studies, right? And there is a financial sort of curve that co-travels with obesity. But we can't trade that, right, for a spend, for GLPs, right? I mean, you could have the same curve or higher, right, in terms of what the overall expenditures are. So, we have to think about what we're spending, right, in the context of the health, right, that we're achieving, and it needs to be done in a financially sustainable way, which I think is ultimately possible. And some of the steps taken, right, to lower the cost, albeit sort of a target approach, I think are necessary, but ultimately insufficient, right, on their own to get us to that place.
Yeah, GLPs are a really interesting case because there's been some studies, for example, Aon has done some work where you look at your spend on GLPs and you look at your spend on other things down the road, and they've done like matched studies, and you can see that you actually are going to be saving money over a longer time horizon. One of the issues,
assuming you continue to take it.
Yeah, assuming you continue to take it, and assuming that the person who's paying for the GLP is the person who's going to be paying for your healthcare down the road. And one of the big issues that we run into with the American system is that because people are switching employers, they're switching insurers, if you're paying for prevention as one insurer, you're not necessarily the person that's going to reap the benefits. And that creates a disincentive to pay for preventive type care.
We could have a whole nother panel on GLPs, which I'm happy to moderate. We'll have you all back, but we'll do that another time. For now, please join me in thanking Andrew Friedson, Jonathan Burks, and Tim Lash. Thank you all for being here.
Please welcome Dr. Meena Seshamani, Maryland Secretary of Health, and joined by Amna Nawaz.
Madam Secretary, thank you so much for being here. It's great to see you. We got the Christmas memo. We're welcoming in the holidays today. Let's start with where Maryland sits in the survey findings. 14th overall for healthcare affordability, access, and quality in that West Health Gallup survey. How satisfied are you with that ranking?
Well, I would say overall, not only as a physician and a health economist, but honestly, as a mom, as a daughter who navigates the healthcare system for my own family, I think there's always room for improvement. Okay. So I don't think it matters if you're ranked 50th or you're ranked first. That is still within the construct of a healthcare system that doesn't always meet people where they are, can be challenging to navigate, isn't always addressing what actually impacts people's health, particularly things outside of the healthcare system. And I think that's one of the reasons that I'm so excited to have the opportunity that I do as the Secretary of Health for the state of Maryland, because our mission really is about protecting and advancing the health and well-being of all Marylanders, and being able to bring together the various aspects of people's lives and the programs that we have and the partnerships that we can have to be able to impact in a positive way the lives of people in our communities.
Where do you see the single biggest chance for improvement?
I think a single biggest chance.
What's sort of the place where you said, this is my priority, we can actually make a real change in this lane?
I will say that rural health is absolutely a priority for us.
Okay.
I think where you see issues in healthcare with lack of workforce so that people can't access care, where you have issues of trust and being able to navigate what are, decisions that can be made, where you're looking at the impact of the community on someone's health, particularly food, and thinking about how food, housing, transportation come into play as we're trying to prevent chronic disease. I think rural areas are like a microcosm of all of those issues. And so, we have made a concerted effort and actually have applied for funding with the federal government now to continue to improve rural health. A lot of times people don't necessarily think of Maryland as a rural state. We have some pretty large rural areas, from Western Maryland and Appalachia to the Eastern Shore and Southern Maryland. And we have an opportunity also to be able to bridge the gaps that are in health right now for people with local economies. So being able to, for example, invest in cold storage. Here is a Secretary of Health talking about cold storage. What's cold storage? How can you create storage opportunities and a hub and spoke model so that local produce can get out to communities? So we have farmland in Maryland, and we have opportunities to further the local economy while also then providing healthy foods to those same communities or to other communities in the state. So really seeing those opportunities to connect the dots. I think rural health is just one example of where that can all come together.
I want to ask you about the affordability piece of it in a moment, but just get your reaction on what we were talking about on the last panel in terms of, because you mentioned the rural access issue, and Andrew Friedson had mentioned community health workers as something that he would stress as, on return for investment, that's a good model for people to follow. Does Maryland employ that model?
Yes, actually, so in my career path, I used to lead care transformation for MedStar Health, which is the big system in the Maryland, DC, Virginia area. And one of the service lines that was under my purview was community health. So I saw firsthand from our community health workers, I'll give one example where there was a woman who was coming into our ER, came in 17 times in like 3 months for exacerbation of her lung disease. And we assigned a community health worker to her who went out to her house and found that her electricity kept getting shut off. So her nebulizer wasn't working, and that's why she kept coming into the hospital. So the community health worker is able to address that issue. Guess what? She doesn't come into the hospital anymore. She's leading a healthier life. And that program actually, the program that trained that community health worker was part of the unique model that Maryland has. Maryland is the only state in the country that has what's called an all-payer global budget model. That's a lot of wonky terms. What does it actually mean? It means that rather than each service getting a payment, like a fee for service, with every insurance company doing it differently with every hospital, in Maryland, we have an aligned approach where across all insurance companies and across all hospitals, hospitals are given a global budget. Here is the amount of money that you get, now spend it wisely for your patients. So you don't have that same incentive of the heads in beds, right? Where if you hospitalize someone, that's when you get revenue. And it really changes the paradigm of how care can be provided. And I went from Maryland to leading Medicare and actually took a lot of my experiences with me, where now, for the first time, Medicare pays for community health services and pays for care navigation, because to your point, we have seen a return on investment with moving care upstream to where people are, and it then provides clinicians and communities with the tools that they need to really take health to the next level.
How long has that system been in place, and do you have data that shows it leads? I can see why it would be attractive to the hospital systems. Does it actually lead to better health outcomes? Have you been able to prove that?
We have definitely. So in Maryland, we have lower hospital utilization than in other states. We have reduced what's called potentially preventable admissions, like admissions from complications of chronic disease. We've reduced readmissions. And I will say on the federal side then, when I worked, running Medicare, we absolutely saw that where there were clinicians coming together to provide more holistic care, they knocked it out of the park on quality metrics compared to their counterparts, and they ended up saving the Medicare program money. So I do think that there is evidence, and I think some of what we all need to do is continue to move the ball forward, and that, I'll be honest, can be difficult, especially in times of uncertainty and anxiety. And that's something, having practiced as a physician, led in a health system, worked in the federal government, I feel very fortunate to be able to bring all of that now to the state of Maryland, because really our goal is to lead during this time with thoughtfulness, with joy, because we go into healthcare because we want to help people and you want to have an impact, and we can have that impact. There's a lot of swirl right now, especially with changes coming at the federal level, and no better time than now for all of us to say, okay, what do we need to do to continue to drive towards our North Star of improving the health and well-being of the people that we all serve?
You mentioned recently applying for federal funding for some programs. Just give us a sense of, at the state level, what has it been like to navigate your relationship with this federal government? Has it changed over the last year?
I absolutely think, it has changed. As my governor, says, as my boss says, that there has been this disruption of a federal-state partnership. That being said, I think for those of us in healthcare, at the end of the day, we do have common goals, and I think there is a huge opportunity for us to continue to focus on those common goals.
You feel you have common goals with the federal government?
So, for example, the application that we put in for the Rural Health Transformation Fund focuses on improving the workforce. It focuses on how are we bringing technology to bear to improve access issues. We have a whole section of our application on healthy food and food as health. So I do think there are opportunities to continue to find alignment, and I think that is what also has led us to be able to work on our model with CMS, with the Centers for Medicare and Medicaid Services. And I think that's important in whatever environment we're in to figure out how we can come back to aligned values, aligned interests, whatever can then help us to take the next steps forward.
On the affordability front, I know you played a leading role in the drug price negotiations in the Biden administration. This administration has also prioritized drug prices in a number of deals with Pfizer and AstraZeneca, another one related to IVF more recently. How do you look at those? What kind of impact are those decisions going to have on Marylanders?
Yeah, well, so when I was in Medicare, we stood up the Medicare drug price negotiation program and did the first round of negotiations with pharmaceutical companies. And importantly, it was very much grounded in, like what we were talking about, what are the common goals that all of us have? You know, we did listening sessions with industry, with pharmaceutical, biotech, with clinicians, with insurance companies, with patients. And at the end of the day, everyone had the same goal. We need to make sure that people can access innovative cures and therapies that they need at a price they can afford. And that was really our foundation for standing up drug price negotiation. And in the process of standing it up, I think it has created an opportunity for more dialogue on what benefits cures and therapies can provide outside of a clinical trial. Because I don't know about all of you, but my life is not a randomized controlled trial. It can be quite chaotic. And I think it's important for all of us, as we're looking at improving the health of people, to really come to where people are. And I think that is something that has continued to create a foundation for what has been continuing in the federal government. And that's something that also comes back to the state level. So Maryland has a prescription drug affordability board. There are a number of states that have such a board. And importantly, Governor Moore signed a law that actually expanded our PDAB so that the upper prices that the PDAB sets applies not just to Medicaid, but it also applies to commercial insurance as well, so thereby expanding that reach in terms of affordability. And importantly, I think the PDAB is also looking along similar lines of how can we capitalize on the increased analysis that's happening with real-world evidence. You know, the PDAB executive director told me, yeah, we read all of what you put out from your first round of drug negotiation in Medicare to be able to see how you all went about your negotiation. So I think there is a virtuous cycle of data and discussions and analytics that the federal government can do, but then also at the state level to be able to take that and to also be able to adapt to local populations, because health ultimately is local.
We only have a few seconds left, but I have to ask you, because the next few weeks we're going to be seeing a lot of conversation and debate around the extension of the ACA healthcare subsidies. How do you want to see that conversation end in terms of what would best serve Marylanders? Democrats want to see, obviously, writ large, the extension of the subsidies. Republicans are calling for income caps and other steps. What do you want to see happen for Maryland?
I mean, I will say that affordability continues to be a huge issue for Marylanders. And I will say that in Maryland, we preemptively had created a state subsidy to help cushion the blow if the marketplace premium subsidies were to diminish. However, It cushions it, it does not get rid of it.
So that would automatically trigger if they do expire at the end of the year.
And yes,
Okay.
exactly. But it cushions it and it doesn't diminish it. And I will say right now, as the chair of the Health Benefit Exchange, we are monitoring our call centers. We are talking to our navigators. How are people navigating the premium increases that they are seeing? Because we don't want people to go without health care. We don't want people to not have health insurance. And so I think it is very important that we are looking at how we can keep insurance affordable for people, because if the uninsured rate goes up, that doesn't just affect the people who don't have health insurance. It affects all of us. Those costs of people still going and getting care, perhaps later than they should have, right? So care is now more expensive. Any of you are physicians in the room, I'm sure you, like me, have umpteen examples of this from your own personal practice. That cost gets passed on to everybody else. Also, if people are not able to keep themselves healthy, what does that mean for how they can come and show up to work as an employee? What does that mean for their ability to care for other members of their family? The ripple effects from people not having affordable insurance coverage goes through our entire country, all of our communities, all of our pocketbooks, our economic productivity. And so I think this is a crucial aspect that we need to be able to demonstrate leadership and really address.
Ladies and gentlemen, please join me in thanking Maryland's Secretary of Health, Dr. Meena Saisamani. Thank you so much for being here.
Please welcome the Democratic representative from Vermont, Becca Balint, and Eleanor Mueller, Congress reporter of Semafor.
Great. Well, thank you so much, Congresswoman, for making time in what is an insane week to be here with us this morning.
I'm very happy to be here.
Amazing. All right, so the topic that's on everyone's mind on the Hill, you know, what to do about healthcare ahead of these enhanced Affordable Care Act subsidies expiring at the end of the year.
Yeah.
You were just home in your district for 50 plus days as House Republicans kept the chamber out. What did you hear from constituents about healthcare?
People are really scared. I mean, that's what I want people to understand. Bottom line, they're very anxious. They're very fearful, not just about healthcare and their situation with the Affordable Care Act and the subsidies going away, but also deep concern among all of my partners within the healthcare industry in Vermont that the nearly $1 trillion of cuts to Medicaid is going to impact the entire system. And that's the piece that I think Vermonters understand, is that it's not just going to impact those individuals and families who are on Medicaid. It's going to impact those hospital systems. It's going to impact everybody else's premiums. They understand that they're absolutely connected. The other piece of this conversation around healthcare that I think is really top of mind for Vermonters too is the attacks on research and development in healthcare and in science. And they know that the United States has always been a place where some of the best researchers and scientists in the world have come to do their work. And we know that. I was a history teacher for years, so I just look at this historically. When you look at what happened during the rise of Hitler across Europe, and you had so many researchers and scientists coming here, and what we are facing now is the Europeans understanding that this is a moment when they can pull researchers and scientists out of our system here, because I think I saw, I don't know if it was Pew that did a poll, no, it was Nature. It was in Nature. 72% of researchers said they are looking to go elsewhere because they don't feel like this is stable and secure. So it is the attacks on research and development. It is the attacks on Congress's power of the purse. When you have rescissions, when you have impoundment happening, Vermonters are very aware of the ways in which this is also part of the healthcare system and landscape. And the other piece of this is every time I go home, and I've done a lot of town halls, I get a question about the health and safety around vaccines and vaccine information and the misinformation that we are getting from this particular cabinet secretary, who shall remain nameless right now. But people feel like it's all very precarious. It's not just this particular situation with the ACA subsidies. They see this as compounded on top of all of the other attacks that we've seen. And fundamentally, access is challenging in rural areas. Vermont is overwhelmingly rural. So it's access, it's affordability, and we haven't really even touched on the issue of the health care that relates to mental health care, and that is a deep concern for Vermonters. So I gave you a lot there, but that's what I'm hearing. And they do not have confidence that the Republicans will put forward a plan, because we've been promised for 15 years that they would bring forward a plan, and they never have. And so why should we trust them now? That is what I hear over and over again.
Well, so President Trump said this morning that he basically didn't want Congress to waste their time on these enhanced subsidies. House Democratic leaders have put forth a discharge petition to force a vote on a 3-year extension of the subsidies. Are there other versions of what Republicans are talking about that Democrats might be open to, whether that's reformed subsidies or different changes like HSAs?
I just have to say at the top,
Yeah.
they have never put forward a viable plan, anything that we could kick the tires on. And to think that we're going to come together on a plan before the end of December is madness, and we all know it. And so I am a strong believer in some version of Medicare for all. And I know that the numbers of Americans that support that concept has been steadily increasing over the last decade. And so a clear, strong majority understand that the system that we have right now isn't working. That being said, that kind of shift in healthcare is not going to happen quickly. And so is it a 1-year extension? Is it 2? Is it 3? What I hear from Vermonters is we want to get to a better system, but right now we cannot abandon these subsidies, because what's going to happen is we're going to lose our healthcare. People can't afford the premium. So on average in Vermont, it would be an additional $800 a month. People don't have that. Bottom line, they don't have that. So forgive me if I'm incredulous when the president and my Republican colleagues say they're going to put forward a better plan, because they haven't done it for 15 years. And they never let us in on the conversation.
Got it. So less a question of whether or not there's something that Democrats would be okay with, and more a question of whether or not there's anything at all.
Here's the thing. Show us a plan.
Yeah.
Have a conversation. Have leadership actually sit down. Have the four corners sit down. That's not happening.
Yeah.
This administration, and I'm just going to rip it off here. I don't have any time for just window dressing here.
Yeah.
This administration is a black box. They are not communicating with us, members of Congress, who are the ones that create policy. And so until that starts to happen, no, we need to extend these ACA subsidies to get us through this emergency that we're in. Bottom line, I don't see any other way.
Yeah. If that does not happen by January 30th, when funding for most levels is slated to expire, do you expect another shutdown?
I certainly don't want another shutdown. When we see this administration withholding food assistance from people, we don't want another shutdown, but I also know that my constituents understand that this is existential for them. Mm-hmm. They cannot afford these premium increases. They're going to go without health insurance. And again, that impacts the entire system. So, we were just talking about it in the car on the way over with my staff. What is going to happen in January? I don't know, but I do know that what has been offered so far is giving none of my constituents any comfort that the people who are running the House and the Senate and the White House understand the pain that they are going through with healthcare right now.
How can we expect that to factor in on the campaign trail ahead of midterms?
I think it's going to be a constant contrast being drawn between the people who have consistently delivered some healthcare program for Americans, whether it's perfect or not. I don't think anyone would say that the Affordable Care Act is perfect, but it provided healthcare for millions of people who didn't have it before. It provided healthcare for people who had pre-existing conditions. It provided healthcare for people who were in that in-between time of leaving the house but don't quite have, a steady job right now with benefits. Are the Americans prepared to have that go away? Absolutely not. And so if we can't get some kind of an agreement, then Republicans will feel the wrath of their voters because they can't make it work. They can't pencil out. And it's not separate from the affordability crisis that we're having right now. It's at the center of the affordability crisis.
Well, I promise to get you off stage by 10 because you have a markup to get to, but thank you so much for being here with us.
Thank you for having me, and I just like to keep it real.
Please welcome Josh Hodges, Chief Customer Officer for the National Council on Aging, Joe Daly, Global Managing Partner at Gallup, and Gina Chon, Executive Editor for Semafor.
Much to both of you for joining us and for all of you watching online and in the room. I'm really excited about this panel because it's on hopefully some of the more positive sides of what we can do about some of the challenges that we've all been hearing about and talking about pathways for successful aging. I was just mentioning I'm sort of going through this now with my own mother-in-law and trying to figure out how she can live the best life in her later years. So I'm really eager to hear your words of wisdom. So Joe, I wanted to start off with you in terms of your perch at Gallup and really being based in data and all the research that your organization does along with West Health that informs some of these possible solutions. So at a high level, what do we mean when we talk about successfully aging?
Thank you. I think this is an amazing conversation to be having because if you look globally, longevity or just the length of time that people are living has been going up kind of year over year around the world, and it feels a little bit like we're confronting this conundrum of now that we're living longer, what is it that we can do to make sure that we have a great life that goes along with it? And, what are the systems we need to support, perhaps the health equation or the community equation that, becomes challenging the older you get. And so I was looking through all this stuff, and you guys, I'm sure this group knows this, but, there's things out there that have been trying to tackle this in the UK around QALYs, which are quality adjusted life years, which are now becoming well-bees, which are your well-being adjusted life years, and trying to put some math to what is a quality, additional year of life that you might experience. Gallup has been doing a bunch of research on well-being, which is looking at, the 5 elements that support, a high well-being life, from your community to your social well-being, to your financial, physical, and purpose in life. All those things sort of add together into this holistic equation. But so as I was looking at everything, I found this one quote, and if it's okay with you, I'm going to read it.
Yes.
Of just one person that I think has an incredible summary of maybe the answer. So it's the person, I'm not going to tell you who it is yet, says, if there are rules for living long, and it seems that there are, they would include these. Don't be fussy about your food and never overeat. Don't worry. Work at a job you love, and if it gives you physical exercise, so much the better. If not, be sure to get your exercise, and lots of it, some other way. Not in quote, but this person goes on to say that they describe their life partners and children as their comfort and pride. They rarely worried about money, and perhaps surprisingly said that more income would not have made them happier. Does anybody want to guess who that quote comes from? It was
Any takers?
It was George Gallup.
Oh.
And does anybody want to guess what year?
Wow, you get a bonus, I think, for that.
And does anybody want to guess what year it was? 1959. So he did a study of people that had lived over the age of 95 back in 1958. And so it's sort of interesting to me, at least, where you look at it. I mean, he answered basically the 5 elements of well-being that Gallup has today, but it was 65 years ago. And what's a little sad, and then I'll stop, but is I think in some ways we haven't really made much progress on figuring out as a society sort of how we make those 5 elements go up. And I think that's somewhere in there is the answer to the riddle around what great aging looks like.
And Josh, in your previous life, you had worked at Health and Human Services on community living. You know, we've heard a lot about the affordability problem when it comes to healthcare and the many sort of financial challenges. But what are the other ways that we can look at what successful aging looks like that's outside of some of the financial pressures? You mentioned in the quote that a higher income wouldn't necessarily have led to a more happy, fulfilling life.
Yeah. Well, thank you. I mean, successful aging is such an interesting concept, right? Because it's so personal. It's so about what matters to you. When we look at older adults at the National Council on Aging, we really talk to them to better understand what matters to them. And the answers really kind of come down to 4 kind of key areas. 1, economic security. Do they have the economic security they need to do what they want to do in later lifehood? 2, health. You know, what does their health look like? We'll talk a little bit more about health, but 80% of people over the age of 65 have 2 chronic conditions. So what does that mean for them individually? 1 in 4 older adults fall every year. What does that mean for them individually, and how do we do that? Then you talk about community connection, and this is so important. How are you connected to not only the community that you want to be connected with, but the community that you live in? For some people, that means they want to keep working. For some people, it means they want to volunteer. Others, it just means they want to attend a senior center or connect with their place of faith. Regardless, it's about self-determination, determining how you want to engage with your community. And then lastly, safety. Do you feel safe not only physically, but do you feel safe that you will be able to have the resources you need to age well? And it really is about that concept of aging well. We believe that we have a duty to create the conditions that everybody can age well. And there's a gap right now between the people who have the ability to and the people who don't.
And what makes the difference in that gap? What is it that the people who are aging well and feel fulfilled and mentally healthy as well as physically healthy, what's the major difference there?
So I think it falls on one of those 4 domains, but it typically, ultimately, is economic resources or health is where we really see the majority of the gap, because that drives everything. When I said 80% have 2 chronic conditions, there are programs out there that help you manage your chronic conditions, that help you not only prevent getting additional programs, but also mitigating the ones you have. But it's about access. Can you get access to those programs? Right now, it's a patchwork across the country as to where those exist. For falls prevention, for example, we know that if you take a falls prevention class, you are 50% less likely to fall. 50% less likely to fall. But those programs aren't available to everybody and not available to all demographics. If we looked at one program, a Tai Chi program, if we spend $45 million to nationalize this program, we would expect to save $1 billion a year in prevention. $1 billion, $45 million a year to $1 billion. I'm not a math guy, but that's a big difference. And so as we talk about, this is the kind of investments we should be talking about societally to make those differences, to put the self-determination back in the individual's hands themselves.
And Joe, in talking about this patchwork system, especially with the research that Gallup and West Health have done, looking at states and kind of the individual metrics, where are you finding the success stories? What do the states have that are doing this well by their constituents?
Well, yeah, so we just did a study of 20,000 Americans, and our attempt really was to look at, the healthcare system by cost, quality, and access. And so, I mean, I think the states that are doing well are, I would say, no state is really, the model here that is, exceeding expectations on all those things. But the states that are, doing some element of that well tend to rise to the top. But to answer a slightly different question, where you say, in that data that we just launched, to me, like the most, when we look at this longevity equation, is I would say, in some ways, like it's somewhat settled in terms of what the health equation is going to be for elder Americans, 65 plus, et cetera. And it seems like, to me, like the big opportunity sits in like the group that's coming next. So I'm going to call that like the 50 to 64-year-olds. And as we're thinking about policy, and as we're thinking about trying to bend the curve into the future, I think like that's our biggest opportunity, is right there, because you're looking at people that are in middle age. They probably have one or two on-ramp like conditions that is going on, and the survey very clearly shows that's the group that's the most worried. I mean, half of them are saying that they can't afford their medication. You see a third that are saying they have real challenges around affording care, and they're actually clearly indicating that they're skipping or delaying care that's needed. And so like there's this whole, obviously conversation about, longevity today, where you look at people that are podcasters and everything, are telling us all these things that we need to be doing. But they are literally that age group. Like what you're doing there is sort of like predetermining, I think, what it's going to look like as you get into the 65 plus. And so the data that we just said, and that's across the board, like every state or whatever, it's that group that I think we all need to be really focused on.
Yeah, and what do you think are the biggest things they can do to make a difference? Because mentioning my mother-in-law, it's definitely made me rethink what I want to plan for, what kind of, challenges I don't want my daughter to have to deal with, when I get older.
Yeah. Well, I mean, there's the care side of it, which is like our healthcare system and how it's able to, from a cost standpoint, provide, we were talking earlier, I can't remember who I was talking to, but it was, take like medicine, for example, in the 50 to 64. Say you go on like a high blood pressure medicine, or you go on some sort of pre-diabetes medicine or something like that. Like the cost of that relative to delaying something like that and then getting into older age and having a heart surgery, I mean, the cost equation is insane there, and that doesn't even get into the quality part of it. And to go back to the thing that I was talking about before, it's funny, for 65 years, whatever, we've known the answer to this, and Americans, by and large, if you look at all the data, we have an obesity challenge in America, we have a diabetes challenge, we have all that. Americans they're not moving more, we're more stressed than we've ever been, our diets haven't particularly changed, but there's kind of maybe two small bright spots, I guess you might point out, which is one is the fact that the Americans are drinking a little bit less in general. You can see that our alcohol trends are declining, which I think that's going to be a good indicator for the future. And the other one is, you guys, maybe we should celebrate a little bit, is obesity has actually turned down in America for the first time, really, since we've been tracking it for 20 plus years. It's been kind of going up like this, and we just bent it down, and I would say you can largely see the correlation to GLP-1s. It's not that we're moving more or being more healthy. It's like you can see the sales data or the self-reported data that we collect in our surveys that we're seeing improvement on those elements. So I think those are really the places, is these lifestyle things where we really need to get focused.
Yeah, and Josh, when it comes to the that age bracket that Joe was talking about. We were talking backstage about how that generation is being sandwiched between having to care for elderly parents or other loved ones and then taking care of their kids. And I loved what you said about how it's not a sandwich. If you could sort of elaborate on that and what you found sort of outside the healthcare system that you think could make a difference for preparing for a successful life later.
Sure. Well, so we often talk about it not as a sandwich generation, but a panini generation. If you think about the panini press is really pressing down hard on both sides. That's the more kind of lived reality of
depressing,
caregiving.
but true.
I think as you talk about successful things outside of this space, you're really talking about starting earlier in the thinking. We often talk about aging is viewed as a destination. I made it to 65. We often talk about that as that's the goal. 11,000 people make it to 65 every year, every day. But the majority of them are going to be 70. The majority of them are going to be 75. The majority of those are going to be 80, and so on and so forth. And so aging is not a destination, it's a journey. And so as we think about it from the National Council on Aging, we're talking about not just the older adults, people say 65 plus, and there is no official definition of older adults, depending on who you talk to, but 65 plus, we're talking about everybody going through that process, whether it's a caregiving responsibility. That often is a first daughter problem. It's often the oldest daughter is typically the one who provides a lot of the caregiving responsibilities. Not always, but it's often that. And that person then has less ability to engage in her savings. She might have to change her career path. She might have to take a different role and decrease her savings. It may impact her health. Caregiving as a caregivers themselves have huge health impacts.
Yeah.
And so
and their mental well-being too,
physical
dealing with those. Yeah.
And so I think it's all about thinking about that from the beginning. When you start viewing aging not as a destination but a journey, it really kind of changes the paradigm for at least the people we talk to, because it really is about we need to be working every day towards what those goals are. And a lot of people in this room and virtually are going to have 25 or 30-year retirements. And so do you have the savings to do that? Do you have the connections in your community to do that? Those are questions I always talk to older adults and caregivers about. As you approach that point in your life, whatever it is and wherever it is, are you ready for that change? Because that change is going to be significant.
And we've talked a lot about what individuals can do, what families can do. In our remaining minutes, I wanted to get your thoughts, especially since we're in Washington, but also given the findings you've had, what policymakers can do, especially at a local level where obviously there's a lot of debate about what could be done on a federal level, but these are a lot of times local issues. There are nuances to think about, the demographics of certain communities to think about. What do you think from a policymaker standpoint, especially on the local level, could be done to help people?
Well, very much the reason why we launched today the 20,000 person study, and we came out with the state, rankings around that was, and we see this in our data everywhere. So you look at unemployment, you look at other things. You tend to have this when you aggregate to the national level. You tend to you kind of lose the story in some ways, because there's places in America where people are on that metric, they're doing really well, and there's places where they're not doing well at all. And so if we can build data and we can build insights at the local level, we think we can highlight, it's both. Look, we can highlight places where it's not working, and maybe it gives a little bit of extra emphasis to policymakers. Healthcare is very much nationally, there's a lot of policy and regulation at the national level, but it cascades all the way to the local level. I mean, you have huge decisions being made at the state level and huge decisions being made at the local level. So if we can highlight places where it's going well, we're essentially providing a benchmark. We're hoping that we're starting a conversation so that people that are doing well, then they know they can kind of look at their framework and start to communicate what it is. Those that aren't doing well can learn from it. And so the whole point, I guess, from Gallup's perspective and with our amazing partnership with West Health is, can we be highlighting those things, and then can we be starting a conversation that's based on what people are experiencing versus an argument about what people should have.
Yeah.
So we're hoping to just kind of lay that down as a place to start the conversation.
Yeah, and Josh, really quickly in our remaining seconds, what's the one thing you think local policymakers could do?
At the local level, invest in age-friendly communities. Age-friendly communities supporting older adults' ability to live in their communities. That's transportation, that's connectedness, that's meal delivery. That perspective. That is one of the key drivers, is the affordability to people who live locally, is that age-friendly community space. And that's a huge opportunity for local governments to invest in.
Great. Well, thank you both for your thoughts. I may be coming to you for advice later as well, so thank you so much.
Thank you.
Please welcome Dr. Sharmila Makhija, Founding Dean and CEO of the Alice L. Walton School of Medicine, joined by Gina Chon.
I was really excited to have this conversation with Sharmila because I, in my other role at Semafor, oversee our CEO newsletter, where the editor, Andrew Edgecliffe-Johnson, interviewed Alice Walton, the namesake of the School of Medicine, where you are CEO. And I loved how blunt she was about the problems we're facing. She does not mince words about the supply, or lack of supply, I should say, of healthcare services in certain areas, and just her own experiences as well. And, you know, obviously she comes from the Sam Walton family, has no problems affording the best in the world, but still facing challenges herself. So. If you could, you know, pardon the pun, sort of diagnose the problem that you and her were seeking to solve, and then I'd love to get into the different ways that you figured out possible solutions to them.
Well, thank you for inviting us to talk about the school. You know, Alice shares very openly her own health needs, and that she could afford to go anywhere in the world to get her care, but it made her really sad that the people in the state of Arkansas had to do the same, but most of them could not afford that. And so really the premise was, how do we fix the health care, initially just even for the state of Arkansas, created what's called the Northwest Arkansas Council, so got a lot of the business leaders together and really looked at the issues as a whole for all businesses, for people that are working there, for even recruiting people into working at these businesses. And then started to look out beyond Arkansas, that in the heartland area, it's a real need, because that's where most of the rural communities are, where you don't have access to good care. That combined with looking at how we deliver the care, even when she could afford the care to go to places, wasn't really listening to the needs of the patients. It was, you know, as many people say, sick care, but how do you prevent this to begin with? So looking at whole health principles, that became the foundation for what she wanted to create in a medical school. And if you go deeper and look at value-based care, which is what we've been talking about earlier, it is really the foundation of that is whole health principles. So just like your previous panel talked about, instead of saying what's the matter with you, what matters to you, and looking at as a whole, what does the person need? Because it's not just about that illness, it's about what are the impacts of that. And so that's what led us to really look at the issues of how medical curriculums are designed. And I think that combined in a perfect storm with my experience of being a department chair in several institutions. I've worked all over the country. We were having to spend a lot of time retraining students that were joining residency programs or residents joining a practice, that they really didn't understand how it was to deliver care. So I vowed to myself, if I ever had the opportunity to, you know, rebuild a curriculum, this is what we would start to put in. And that's how we designed the curriculum, to put in practical pieces as well into the curriculum.
Yeah, so what do you guys do differently? Because obviously you want, students who score well on the
Right.
MCAT and, all the metrics that we know that are based on statistics.
Yes.
But a lot of what you're talking about is sort of, the more softer skills.
That's right. And, there are softer skills, but I would say that those are the essential skills that are really important to a patient, to a person that's being taken care of. So yes, we clearly have to make sure they can pass tests. They can, their MCAT scores are good, their science GPAs, they can do the work. But what we've done that, some schools have started to do, we've intentionally built it in to the curriculum all 4 years, is bringing in the arts, right? We're sitting on the campus of a world-class museum. We have educators at the museum that are teaching middle school kids how to look at art, and it's shown to improve their empathy, their resiliency. So we're using those same educators to teach in the medical school. So we think that is really going to, especially in light of technology coming to play, that human interaction is going to be even more important than we see now. So we've put that in a very intentional manner, and we feel that actually helps them as a student know how to take care of themselves as well, so that the burnout issue that we talk about can come into play to help them with that.
Yeah, and so with the technology aspect, I also oversee our tech coverage, and one of the uses we were hearing for AI was doctors asking, a chatbot how to deliver, bad news or upsetting news in the most sort of gentle way. I mean, is that something that could be incorporated?
Absolutely, because if you were lucky enough or fortunate enough to have a mentor that you happen to be rotating with, that you got to witness how they did it well, and that happened for me in my own training as an oncologist. So I learned how to do it, but not everybody has that same experience. So you're now able to amplify that ability and spread it across for learnings. So absolutely.
Yeah,
absolutely.
And in terms of the sort of supply and demand problem, especially, we were talking in the last panel about our country's demographics, and many countries are facing this, where the aging population is just going to overwhelm the healthcare system. What are you doing at the school to try to hopefully place some of these students in places where, there's frankly not a doctor, a primary care doctor even around?
Yes, I mean, again, coming back to Arkansas, and as is what's similar in most heartland states that have a lot of rural areas, you will have maybe one doctor, likely to have no doctor in those communities. So one thing we have done that we feel is important, we wanted to bring back in those students that have those backgrounds of growing up in a rural community. You're more likely to feel connected to go back and serve in your community. So, I think on average nationally for medical students, there's less than 5% that are from a rural background. Our first class is 15%, and we want that to increase. So that's one piece that we're doing. We very much are focused on the recruitment of students that are engaged in community. So the community service they've already done, and then within the first week we have them into the communities, focus on particular areas to work in the community. But that's not necessarily enough to do, right? Because even if you produce one that goes into a rural community to serve, burnout is probably very likely because you're on your own. So is
the burnout rate higher than rural areas because you're a bit isolated?
You're a bit isolated, and you don't have a colleague to talk to, and patients don't want to necessarily go and be referred out, so they come to you for everything, right? Which is understandable. But what we are also doing that Alice, she's not naive to think that you can just focus on a medical school. You have to look at the whole picture. So she's got an institute that works at policy and payers. She's also building out a healthcare campus that we're about to break ground on, that we're teaming up with Mercy Health System, and we want to utilize the virtual care network, not only to improve the access for patients to be seen, but to support those rural doctors out in the communities, even if they're not affiliated with Mercy, to bring them in, to be able to contact us and say, hey, I've got to run something by you. Can I manage this here, or do I need to send them? We'll help them send them wherever they need to go. But we want to provide that virtual care access for those community doctors as well.
Yeah. And so what is your outlook on replicating what you're doing or what others may be doing at scale? Because obviously,
Yes.
you know, we were just talking, this is a national problem, but then each community, each state has their
right.
own nuances. So
Right.
you have to scale it, but then also tailor it at the same time.
So we, you know, as we're creating this, we, you know, clearly we are fortunate to have the backing of Alice as our founder. But we also want to be able to replicate it in a very fiscally sound way. We're very careful with our budgeting. We're trying to see what are the essentials that we can use, that we need in-house. How do we share resources, right? If we look at Arkansas again, you know, there's 2 now allopathic med schools, 2 DO schools, very limited resources. Sharing faculty is what we've been doing. We've been trying to see, even with research, we don't necessarily need to rebuild labs. How do we work together? And we've been working with the University of Arkansas as well in the research area. So we're trying to utilize and create a model that shows how do you resource things in the proper way. And then looking at the curriculum, we know this is what we need for our community, for the whole state. But how do we create a model that you can use in any state that looks at the community needs? And so, you know, we've been working with federally qualified health centers because they have really a finger on the pulse of what's going on not only for the state but for nationally. So we're working with a lot of different partners to understand the needs, but creating this model that can be shared with others.
Yeah. And how much help do you need from state legislators, from Washington, from others that may be controlling, you know, fiscal budgets and thinking about all of that versus, you know, if you have a benefactor like Alice, you know, you can do a lot yourselves.
You know, we work very closely with the state, the government. We work closely with the governor's office. You know, in the end, when you are creating models to be able to keep the doctors in the state, when you look at how reimbursements are made, I mean, those are policies that really have to be looked at. So her Whole Health Institute team looking at that as to how do we create that model, because, you know, if you even look at the reimbursements for Arkansas compared to our neighboring states, we're much lower. So even if we create, you know, have an alluring reason for the doctors to work with us, they're going to migrate out because of that. So just even looking at that, which is massive, right, to do. But it's important. You have to work. You can't do it as a silo. You have to collaborate on the state level and federal level for sure.
Yeah. And what are other incentives besides sort of on the financial side? Because you talked about burnout, you know, not feeling isolated, and thinking about this as an ecosystem for both patients and for the providers.
Yes.
What are the other things that are outside of money, basically?
So, you know, when we look at even our curriculum, and many schools are starting to do this more and more, but when we designed this 2 years ago, we put in, you know, understanding nutrition, right? If you look at what patients are asking for, yes, for sure, they want to know how to take care of this illness, how to prevent it maybe, but we haven't armed the students in learning that knowledge. So we've put that in, again, all throughout the 4 years. We're teaching them about their own well care. And so even how we've designed the building to be very part of nature, part of the forest, part of a trail system, so that their environment that they're learning in a very intense period of time, they're learning how to modify and manage and communicate this in a different way, right? We have teams that are helping them understand themselves so that they can, in turn, be able to share that with patients. So we're trying to put everything in that we see is wrong and trying to address it. And I think many schools are trying to do this as well. We have the luxury of starting off at the base and creating it from the ground up.
Yeah. And is the thought that if you start it there, it'll stay
carry
with
on
them for their careers?
Yes. And you know, even our partner with Mercy, we have the doctors there that are practicing value-based care, teaching in the curriculum, so they're learning it as well. But they're also teaching it, practicing in simulation, and then we have them go within 3 months into an early clinical experience, working with those doctors in real time to see, are they able to apply it? How do they apply it?
And that's much earlier than
Much
you would
earlier.
normally.
So they still have clerkships in the 3rd and 4th year. And again, that's a luxury that we have because we have a great partner that understands the value of that. But I think that's important for students to be able to experience that because, and it's an outpatient setting. You know, most of the clerkships are really in the inpatient setting. So when they go out in the real world to practice, there's a disconnect. So we're trying to move the care delivery into the learnings early on and how the realities are of how we do this.
Got it.
Yeah.
And just before we go, I wanted to ask you for your own medical education and now seeing
Right.
some of the differences, some of the innovations, like what's the one thing that you were like, man, I wish I had that when, when I was in medical school?
You know, I think many of us that are in my same age category, we were in a very dark room. We, you know,
No
we had
windows.
lectures all day long. This environment that we're creating is really showing that we want you to continue living and enjoying life, right? And I think when I was in training, we didn't really talk about that. It was actually, you were almost told, you know, keep it to yourself, just you got to be tough, which I understand that to a point because you've got somebody's life in your hands. But it was a little too dramatic. I mean, I think being able to communicate and talk about what you're thinking and how to improve things, we're always engaging our students, our faculty or staff to tell us, how would you do it better? How do we really work on this together? And I think that openness is something that's different. I mean, I think it's, you know, there's a balance of that, right? You know, we can't change everything that once we start to work on a curriculum, you can't have that constantly changing. But getting the input to understand where we can do it better and improve, I think that's really important.
Yeah,
so.
and understanding doctors can have a life too.
That's exactly right. That's
Thank you so much.
Thank you so much. Thank you.
Please welcome Dr. Fritz Francois, Executive Vice President, Vice Dean, and Chief of Hospital Operations for NYU Langone, and Amna Nawaz, co-host of PBS NewsHour.
Hello. Dr. Francois, so good to see you. Thanks for being here.
Thank you so much. It's a pleasure.
I'd love just to get your take on kind of pulling back on all the conversations we're having today, the results of that survey from West Health and Gallup, that how Americans are viewing their healthcare right now, not giving it good grades when it comes to overall healthcare, to the cost of healthcare, to the outcomes that they're seeing. From your perspective, just what's your reaction to that? Does that surprise you?
It doesn't surprise me.
Yeah.
And it's understandable for a whole host of reasons, namely because there is a reality of what patients expect of healthcare and healthcare institutions. You know, it's interesting actually to see the report because this was an opportunity to put a finger on the pulse of what is happening. And it is something that's near and dear to us as an organization, where we went over the past 2 decades, we've undertaken this transformation, believing fiercely that it is important to deliver on quality for patients. And we had to look at ourselves and put a finger on the pulse of what is it that we're doing.
Tell me about that transformation. How did that take effect?
Well, you know, the first thing that we had to do is to recognize that we did not have the data. A lot of organizations don't look at themselves and say, what are we doing? Do we really understand what's happening? Or do we think we are delivering the quality of care and having the outcomes that we think we're doing? And so when we started looking at this, it was surprising. It was surprising in this way. We, as a way of looking at it, we started looking at our data, and there's an organization that looks at objective measures, Vizient, and we were ranked terribly. I mean, terribly.
Across the board.
Across the board, we were terrible. terms of our outcomes, hospital-acquired condition, et cetera. In fact, if memory serves, we were probably ranked among academic institutions 58, 60, around that area.
That has to be sobering.
It was quite sobering. And we'd had to do the hard work, saying this is not acceptable, our patients deserve better, and we put things in place to then look at every aspect of what it is that we were doing. And that included looking at things such as standardization of care. So what I mean by that is it acceptable if you have 10 cardiologists that the way in which they're managing heart failure is 10 different ways? The answer, of course, is no. And you can imagine how the cost differential associated with that, and if your outcomes are variable, that wasn't acceptable. So we had to do the hard work of looking at ourselves and saying, yes, we need the data, we need to understand what is happening, and we ultimately built a dashboard system of over 800 metrics to look at everything, process measures as well as outcome measures, and we held ourselves accountable in terms of goals related to what our patients expect. And we began to get better. And I'm happy to share with you that over the years, in fact, having done that work, we now are #1 in the nation in terms of quality outcomes for 4 years in a row in Vizient. But it took time and dedication.
Well, this is a perfect segue to my next question, which is the fact that you have for years been consistently receiving a top safety ranking from the Leapfrog Group, that's an independent healthcare watchdog. This is your 11th consecutive year.
Yes.
So what do you attribute not just that ranking to, but also the consistency? Because it's fair to say hospital systems have been through a lot in the last several years. So how do you do that? How do you maintain that level?
Well, thank you so much actually for pointing that out, and it is true. But I want to stress that it does require accountability, the willingness to look at the data objectively and honestly, and have those difficult conversations about the expectations. And I will share with you that part of that transformation for us took place in an interesting way, where often people say, well, certain hospitals cannot achieve good outcomes. Namely, if you are a safety net hospital, or if you're in a particular area where you're serving certain populations, you cannot achieve good outcomes. And we thought otherwise. We were very aspirational. We said, no, we're going to challenge that notion. And so what we did is, like, once we started getting better in terms of delivering quality care and safe care to our patients, and really doing this, and delivering value, we had a full asset merger with a failing safety net hospital in Brooklyn, which has one of the highest concentrations of Medicaid patients. And within 4 years, that particular hospital started having outcomes that were comparable to our campus in Manhattan. And I will tell you, I'm very proud of the fact that today, they actually rival us in terms of outcomes. And when I say outcomes, just to be very clear, we're talking about objective outcomes. What is it that you expect as a patient when you go, let's say you go to the hospital? Well, patients who come to the hospital expect to survive. That's important. So mortality rates actually are low. You expect that you are not going to get a hospital-acquired condition. You expect that you're not going to spend undue time in the hospital, meaning the length of stay is lower. And if you are discharged, that you don't have a high rate of readmission. Those things that I just mentioned, which are objective, is exactly what happened to that particular hospital. We did it because we did not separate ourselves from that hospital. We said, we're all in. That hospital, in the Manhattan campus, we had one playbook, one standard. Their goals are our goals. Their standards are our standards. And when we did this, going from the Brooklyn, the community, and then now in Long Island, it was the same thing, which is a different model from a lot of institutions where, yes, they are a system, but the hospitals are separate. We are all in.
So overall, how do you close that gap? How do you, not just with the Brooklyn hospital, but in terms of maintaining your standards, turning around the data in your favor for the better outcomes? Are you spending more per patient? Did you increase the time that providers have to spend with each individual? But what are the steps?
It's a fantastic question. And so there are 3 things that I would point to. The first is the accountability associated with looking at ourselves, taking the vital signs and looking at the data, being honest. A lot of places and a lot of people, if you don't look, it's like, well, there's nothing to do.
Yeah.
The second is objectively looking at outcomes, which I've shared process measures as outcome measures. And there are times in which we know we need to do better, but not being satisfied about those outcomes, meaning there's always something that you can do. And here's why. My philosophy in my conversations with my physicians is this. Yes, we are #1 in Vizient. Yes, we have 5 stars in CMS. Yes, we are leapfrog, et cetera. But I'm not going to lie to myself or to them to say that if we have a bad outcome for one patient, that's one too many. And that attitude makes a difference, meaning we are willing to look at every single case where there's an opportunity to do better. There's one more thing, value. So the value proposition is this. Although, yes, we have good outcomes, the question is, can we do better when it comes to costs? And doing that means that looking again at ourselves and asking, where are the opportunities to reduce waste? Here's an example. We just challenged our surgical departments to look at whether the use of various equipments are standardized, meaning if the two of us are surgeons and you decide that you have a tray that is twice as expensive as mine, but our outcomes are the same, that's a problem. Now, notice what I said. Our outcomes are the same. So we can have good outcomes because we started from the premises that we're doing well. Why would we look at that? It's not good enough. We have an obligation not only to patients, to families, and to our communities to do better. And so that's how we're tackling that problem. And having that philosophy, I think, has engaged our 53,000 staff around this is our mission. And part of that is recognizing that as an academic medical center, we have a tripartite mission of not only delivering the best care, teaching the next generation of physicians on how to think about healthcare today, and adding to new knowledge from the perspective of research.
So what are your physicians doing differently than they would in another hospital system? And could other physicians be doing what they're doing?
So anybody who joins us at NYU Langone understands that we hold ourselves to a high standard of not being satisfied with that
I mean, the
standard.
standards and accountability piece I get, but what are
Absolutely.
they actually doing day to day?
So on a day-to-day, what I shared with you about the data and the dashboards they have access to, we expect, it's like a
So in
report
real
card.
time, they're
Real
getting
time.
feedback on how.
Real time.
Yeah.
If you are doing a surgeon or if you're doing I'm a gastroenterologist and I do procedures and I know exactly what my performance is.
In terms of meeting expectations of people coming in.
And also relative to my peers.
Okay.
Which is important.
Oh, yeah.
Which is absolutely important. And make that transparent because again, if I could learn from you, why not? And that aspect of a learning health system has been really, really important and transformative for us.
So you've heard a lot about the affordability conversation we've been having on other panels as well. I'd love to know more about the community that you do serve and in this moment, what you're expecting looking forward. We talk about this time of uncertainty, the potential expiration of the healthcare subsidies. How are you, in your role, viewing all of that and what could be ahead for the hospital
It's a
system?
wonderful question, and it is going to be a challenge. Recognizing that we serve a very diverse community. We have a campus in Manhattan. I mentioned actually that in Sunset Park, Brooklyn, the highest concentration of Medicaid patients, and also we are in Long Island. The reality is last year, our contribution to charity and uncompensated care was $2.3 billion. That number will rise with the changes that are for the ACA subsidies. But our commitment to those communities is unwavering. And so we will absolutely be there for those communities, thinking about how do we provide care in a way that allow individuals to live productive lives. To that end, even though I mentioned what we're doing in the hospital, we have 7 hospital locations, over 300 ambulatory sites that are located in and near the communities where we serve individuals. The reason that's important is because we do believe that it is important for us to consider and to focus on the social determinants of health that will help patients and families and communities stay healthy. An example of that, where we've been focused on, for patients who have heart failure, let's say, if they get hospitalized and they go back home, what happens to these individuals if they have food insecurity? We believe that food can be medicine, and so we have medically tailored meals for these patients that would allow them to then make it less likely that they're going to be readmitted. So the philosophy of thinking about nutrition, thinking about what it is that can impact care, is really critical for us. So those are the things that I'm thinking about now, because the way in which we deliver healthcare needs to change. The expectation that patients have to come to us and it's just one model, I think that's antiquated. And so we are thinking and delivering new ways of engaging patients, families, and communities in a way that meets their needs.
I'd imagine that's a more expensive enterprise, though, to change the paradigm that way, to go where people are. You mentioned $2.9 billion in charity care last year. Do you have an estimate for what that could be ahead, and can your hospital system afford it?
So it's a great question, and although I don't have an exact estimate in terms of the reason that we look at it as important in terms of doing the things that I mentioned is that it's an investment. It's an important investment that ultimately will reduce the need for more expensive care.
Over the long term.
Correct. Right? So what I just described, for that patient who has a medically tailored meal who had heart failure, if that patient does not get readmitted, it reduces costs. And so we can apply the same principles in a variety of ways when it comes to population health in order for us to reduce costs. So we see it as an investment, as a really important one as an organization.
I'm really curious from an operational standpoint. We talk a lot about technology and how it can be deployed to specifically better health outcomes. We're seeing this around the world. And I'm really curious to know how in your role you have been able to use or deploy artificial intelligence or anything to improve affordability or improve access or improve outcomes. Is that something you're prioritizing, and how does it work?
Yeah, I'm smiling because absolutely, we are very, very excited in this front in a number of ways. So our previous panelists actually talked about aging. And we believe that it is possible to bend a curve when it comes to the decline. If people think about aging in terms of there's a natural decline, but we believe that you can bend a curve in various ways. And we're looking at this but through not only artificial intelligence to understand the phenotype associated with aging, but what is it that we can do to allow individuals to gain function and so they live more productive lives. So we're really excited in that front. In fact, actually we have an institute for optimal aging. With that idea, we're going to bring we've brought in the best minds to really think about it in this way. So that's one aspect. The other is to think about artificial intelligence as a co-pilot to how one can think about or physicians can practice. The reason that's important is because you mentioned how do our physicians manage the things that we are doing. We want to reduce the burden associated with charting and being on the computer, but rather you should engage with the patient. You should have more time, not less. And so the tools that we're developing and that we are implementing would allow for that. Moreover, remember I keep coming back to the notion that we recognize that we're not just taking care of patients. Take care of patients, families, and communities. So what does that mean? We need to understand more about those groups so that we can actually better serve them, and that's where artificial intelligence can also help.
Is that technology being readily accepted by the physicians? Is that something they're like
excited.
to employ?
And I think they're excited, but to be quite frank, there's always a learning curve. It's something new.
It's a very diplomatic answer.
It is something new. Epic, look, the electronic medical record had a lot of positives, but it wasn't designed for patients and physicians. That's really not the purpose. Yeah. And so we are obligated now to really think differently about this. And the wearables, and one of the panelists actually talked about this. We believe that that's actually going to be important as well for us in terms of thinking about how we deliver care differently. Combine that with telemedicine, et cetera. It helps in terms of access. with the idea that it's not always true that the patient needs to come to us, but rather we need to think about how we deliver that care to the patient in a very different way.
Fascinating conversation. Lots more to talk about. We have to leave it there for now. Ladies and gentlemen, please join me in thanking Dr. Fritz Francois. Thank you so much.
Please welcome Shelley Lyford, CEO of West Health, and Justin B. Smith, co-founder and CEO for Semafor.
Good morning.
Hi, good morning.
Nice to have you, Shelley, here. So
thank you.
Let's just kick off with some quick introductions. So
Okay.
Shelley Lyford is the CEO and chair of the West Health Institute, but also the CEO and chair of the Gary and Mary West Foundation.
Correct.
So welcome. Thank you very much for your partnership on this morning's and today's event. It's a big deal for us at Semafor, one of our first significant forays into the healthcare space. So it's very, very exciting for us. But
You're courageous.
well, we took on news. That was a tough one too. Yes. So before we start, just Shelley, please, it would be great to kind of set the table and tell us a bit about the mission that you're undertaking at West Health, and maybe even a little bit about the
Sure.
founders behind it,
Great.
Gary and Mary West.
I love having the opportunity to speak a little bit about Gary and Mary West. West Health is a unique family of organizations with a really kind of direct and unwavering mission dedicated to making healthcare accessible and lower cost, and assuring that older adults in America have the opportunity and the resources that they need to be able to age in place. And so with that mission, Gary and Mary West created 3 different organizations that all work together and were knitted together with this same mission. We have an applied medical research organization, the West Health Institute, located in San Diego. A few blocks from here, we have our West Health Policy Center. And then, of course, in San Diego, we also have our foundation. And the foundation really acts as the catalyst to be able to fund some innovative research. At the medical research organization, we take that research, we're able to pull together data, we're validating new systems of care, new operational efficiencies. We package that up, we bring it to Washington, D.C. or different state capitals, and we're able to influence more enlightened policy. So Justin, I really look at it as 3 legs of a stool. So a unique organization with 3 different levers that we can pull in different circumstances to create scalable and sustainable architecture for better healthcare, more accessible, lower cost healthcare. And this was all crafted and created by Gary and Mary West, who are billionaires hailing from Nebraska, something similar that we have here at Gallup. Gary and Mary West don't have children. They've got billions of dollars, and they are dedicating their entire fortune to assuring older Americans have access to low-cost health care.
So thank you for that. So let's dive in quickly. Just would love to hear your perspective as a CEO on this new West Health Gallup Center for American Healthcare, which is building on a longer-term partnership, as you mentioned, between West Health and Gallup. What's unique about this center? There are many centers around healthcare policy. What is unique about this one, and how is it meeting this moment in America?
Well, the timing is perfect, right? It has to happen now. And what we're doing with the West Health Gallup Center is focusing really compelling data by zip code and region and marrying it with the lived experience. And I think that's what's missing in this narrative in our media, where things are so polarized, things are so partisan, and things are, especially healthcare is so weaponized and to be able to take the lived experience of somebody from Omaha versus someone from Birmingham, Alabama, somebody from Burlington, Vermont, all very different parts of our state and slightly different experiences, but somehow there are also similarities. My colleague Tim Lash spoke a little bit about the similarities, even though you think you're on a spectrum and things in Boston have to be very different than the way that they are in Arkansas. Maybe there are more similarities than you know.
So, fighting polarization in healthcare.
Yeah.
Oh, interesting.
Yeah.
So, a fellow polarization fighter on stage, which is great. Are there any sort of live examples that you can share? Maybe, I mean, I think I might just be leading the answer here, but I believe one of your projects actually involves getting funding from both President Trump and Governor Gavin Newsom, which is, talk about fighting polarization with an effort. Can you talk a bit about that?
Yeah.
And how that came about?
Yeah. What is the saying, Justin? That's something about odd bedfellows?
Yes, unusual bedfellows.
Unusual, exactly. So I'm very proud of, so an example of the work that we do at West Health, again, these 3 different organizations that come together under our one mission. We are very focused on more, let's say, like venture philanthropy. We work outside of the box, just like you do. We're not going to solve the problems that have been created in this country for decades by the usual suspects. And so we're very happy to think outside the box and bring people together in slightly unusual ways. And to that end, West Health was very excited about being one of the founding partners of Civica, which is a nonprofit generic drug company based out of Utah. And we launched the Civica company with 7 healthcare systems and 3 foundations, Arnold Ventures, Peterson, and West. And together we came together and said, listen, like, we need a better mousetrap. We need to fight the high cost of drugs in a better way. Let's disrupt that. Let's create this nonprofit generic drug company to do something different. That was created and launched right before COVID. And during COVID, we experienced drug shortages. We experienced the inability to get API from India and China. Life was different. Life was scary. Trump won. The first administration of Trump took a bet on Civica and said, listen, we're going to give you $100 million to create a state-of-the-art manufacturing plant 60 miles down the road in Petersburg, Virginia, and we want you to create American jobs, create American drugs with American API, and we want you to provide part of that into an American stockpile to assure that we will never go through drug shortages like this again in the United States. So fast forward 6 years to where we are today, that drug manufacturing company, that manufacturing plant is coming online. We're creating drugs, stable, low-cost, generic drugs. We are launching a generic biosimilar insulin. And who is our first big customer? The state of California. Governor Newsom has provided Civica with a $50 million contract, so Civica can provide the state's Medicaid population with generic insulin. So how many opportunities do we have? In fact, I think Semafor should have the press conference at Petersburg with Governor Newsom and Trump.
If you get Donald Trump and Governor Newsom, Semafor will turn up. I promise you. We will definitely stack the front row with a bunch of our journalists.
That would be
interesting.
great. I think we should do it.
What a fascinating story, because you do hear about this polarization across so many different sectors, but across healthcare. And then breaking through with, as you say, kind of a new model, because you're a relatively young organization, right? In the big picture.
We are. We're the new kids on the block. We're only 15 years old.
Yes, the new adolescent on the block.
Exactly.
Yes. So let's talk a little bit about the moment we're in right now, the location. We're here in Washington, just blocks from the White House. We just had the government shutdown that hinged on healthcare. Why is it so important for you to be convening this conversation here in Washington, D.C. right now?
Right. Well, I mean, obviously, time is of the essence, right? Just like that moment when we were able to capitalize on this moment during COVID and create a drug manufacturing plant, that's what's happening right now. I think we're able to capture this moment, shine a light on different ways to move forward. Like, you know, we are only 15 years old, but we have created some really interesting pathways where we are providing folks with lower cost drugs. At Northwestern healthcare system, we've created a new opportunity to move forward to provide many more tens of thousands of people with behavioral health access. So working,
this is another large example.
This is another large example of some of the work, the tangible, real-world difference that West Health is making in the lives of not only older adults, but of all ages. And at Northwestern, we are integrating behavioral health into primary care practices, allowing behavioral health services to become accessible. And we've grown from 4 clinics to 75 throughout Chicagoland, providing tens of thousands of people with access to behavioral health that they didn't have before. The Congresswoman from Vermont was on the stage earlier talking about the mental health crisis that we have in America. West Health is addressing that, and we're doing that in Chicago, and we're actually exporting that into different places, including New York.
So, I mean, there's so many, I mean, what you've just described involved these sort of webs of partnerships.
Yes.
Crossing the aisle, partnerships with Gallup, this new center, partnerships with us at Semafor. So is collaboration sort of your key strategy as an organization in order to reshape the national debate on healthcare?
That's right.
Or is there, can you expand on that?
Collaboration, partnership, and I think, again, like with unusual suspects, with Semafor.
Thank you. Well, appreciate it very much. In closing, would you like to share anything else about West Health or this morning's conversation?
Yeah, well, I feel like we're right at the beginning of the journey. We've got some great tangible wins. We're excited about partnerships across the United States. Our focus, of course, is on this older population that consumes more healthcare, but what is good for an older adult is good for an entire community and the entire family. So really excited about the opportunities moving forward. Everyone that's been on our stage this morning are people that we will partner with.
That's great. Well, listen, thank you so much,
Thank
Shelley.
you.
Please join me in thanking Shelley
Thank
Lightford.
you. Thank you.
Please welcome Dr. Rahul Gupta, President of GATC Health and former US drug czar, and Morgan Chalfant, Deputy Washington Editor for Semafor.
Dr. Gupta, thank you so much for making the time. We're really excited to have you here. I wanted to start just because we're at a really interesting moment for healthcare, obviously coming off the government shutdown, big conversation about what's broken with U.S. healthcare, how to make it better. What do you think the solution is? What's, I guess, the biggest hurdle that we face right now?
Thanks for having me, Morgan. I think when we look at the most recent polls or otherwise, or even the reasons for shutdown, the biggest challenge we have is the rising cost of healthcare while diminishing trust in healthcare at the same time. So I think it's an opportunity for us to consider how do we do a paradigm shift in transforming our healthcare system into one that is more efficient at the end of the day, but people begin to trust it, because that trust is very low right now. And I, as a practicing physician, can tell you that is so true. People are more deferring their care. They're worried about the rising cost as well as the quality.
And how much is politics to blame there in terms of the trust?
Look, I think the more polarized we become in Washington, the more polarized the country gets. That's as much as what Americans don't like. I will tell you that when we pushed for Medicaid expansion in West Virginia back in 2010, the charitable clinic at which I was seeing patients, we were seeing about 20,000 patients a year. Today, I'm seeing about 55,000 patients a year at the same clinic.
Wow.
So what that means is that the working poor, those who are un or underinsured, more of those need our help, yet we tend to believe sometimes that our problem has been absolutely fixed by, Affordability Care Act and other aspects, but it hasn't for Americans on the ground.
Mm-hmm. And you obviously held a very important role in the last administration directing the Office of Drug Control Policy. I want you to imagine you can magically go back into that role right now. What of the Trump administration's strategy would you keep and what would you do away with?
One of the first things we did when the president asked me to develop a national drug strategy that addresses, go back to the balancing the demand and supply. So we pretty much split the $44 billion into almost 50% demand focus and 50% supply focus, but in different ways. The demand focus goes to getting people life-saving medications and access to care, as well as lifelong recovery services. The supply focus goes to really dismantling the networks of the cartels, like financial networks, and so it's acting more smarter, not repeating the mistakes of the past. This is the reason we've gone from about 111,000 deaths at peak to about 73,000, which is about 34% reduction. But we have too many deaths still happening. So what I would suggest is that we continue to learn from our lessons of the past, know what works. We, I think, now know that getting resources to communities, to people who need, look, 1 in 7 Americans today suffers from substance use disorder. That's about 49 million people. So we need to figure out how to help those folks first, and then at the same time, the drugs are coming into the country because there is a demand signal that happens, and at the end of the day, it is a business, and we have to treat it like that.
Right. I'm wondering, obviously the Trump administration just came off these talks with China. There's a commitment on the side of the Chinese to, curb fentanyl, do more to do that. Do you think that the Chinese can be trusted to hold up their end of the bargain there based on what you saw in the last administration?
I don't know if I would describe the relationship as one of trust. What I could describe it as that when we go down by 40% deaths when we talk about fentanyl, it certainly does not happen without the cooperation of other governments. That includes the government of China, Mexico, Colombia, and others. And part of that's that the bad guys all over the world are bad guys, and the good guys in government are trying to control the bad guys. So it's really important that we find ways to collaborate to achieve those outcomes that we want. And part of that's talking to other countries, nations, whether it's allies or adversaries, because American lives are at stake. So a lot of the work would not have been accomplished in terms of saving American lives if we didn't have cooperation of the People's Republic of China. So there's ways to get progress made by transparency and verifiability of the actions. And that's what's important to make sure that those actions are meaningful and they're impacting, and this is what we need.
And your role wasn't based at the Pentagon, but I do have to ask if you think that these strikes on alleged drug boats are actually effective, and do you think what the administration is saying about the those boats transferring these kind of drugs to the U.S. hold merit?
Well, so there's about 2,500 tons of cocaine that comes to the United States every year. That's not because it's not wanted. There's a demand signal there. Now, the challenge is that striking the boats is like a splash in the water. It's not the undercurrent, the challenge that we seek. So I don't think we're going to be able to strike our way out of this enormous epidemic. But I do think that if it's symbolism, then we have to move from tactic to a strategy, and the American people need to understand and know what that strategy looks like.
And then when it comes to the administration's approach to lowering drug costs, do you think that the way they're going about it is the right way? I mean, is most favored nation the right way to go, or are there better ways to do that?
Morgan, I think that's a very important question. Look, about 17% of $5 trillion is spent in healthcare. A lot of it's hospital, doctors, and pharmacy cost, but pharmaceuticals are the highest rising of those three elements. And every president that I know in my adult life has done something to address the tip of the iceberg, which is whether it's Inflation Reduction Act or Most Favored Nation. What we need to be looking at is the fundamental reasons why the cost structures are so high. And that goes back to drug discovery and drug regulatory processing, basically. Now we have the opportunity through AI to actually significantly reduce cost to drug discovery process, which actually will help democratize drug discovery and regulatory mechanism. Now, this administration has done a lot of positive things in terms of AI adaptation. I think there's more ways we can go in terms of phasing out animal testing, reducing the amount of time it takes, using AI and in silico processes, and that's kind of what I'm involved in my daily life. Is right now, 90% of the molecules that are discovered never make it, and it costs hundreds of millions of dollars to process them. And that's why there's no investment interest in those. We're able to now predict with 90% certainty a molecule, whether it will succeed or not. That's a game changer. That's taking, more shots at the goal. There's more investment interest because of that. And I think that's the kind of phenomenal sort of paradigm shifts we're going to need in drug discovery as an example of the adaptation of AI in order to move healthcare costs and really bend that curve.
And this is actually a conversation that I'm continuing from the green room with you, but I mean, how does the federal government actually catch up to that? I mean, how do you incorporate the artificial intelligence into, the way the federal government operates and evaluates these things?
In Washington, and many of us know that, we often get stuck between open government, closed government, job losses, not job losses. I think what we have to be asking and demanding is the quality and the skill set of people. So when we talk about adaptation of AI, for instance, I'll use FDA as an example, and others are there too that I work closely with. We have to be looking at, are regulators trained in AI? Are they able to adapt to AI? AI, in my view, and technology is the most revolutionary aspect we've had in drug discovery in the last half century. So it's going to be important to start asking the hard questions, which is about technological sort of skill sets that exist or don't exist. So it's not about the volume of workforce, it's the quality of workforce within the federal government. And the same can be replicated in state and local government that we should be looking at. Private sector does this really well. And for some reason, we think the bodies in federal government can still stay the same and not be invested in training. And that's the part that we have to be asking questions about.
So it sounds like you wouldn't necessarily be opposed to the cuts we've seen, but it's more, making sure the workforce that is there is trained and.
Yeah, I mean, cuts is just in some ways a distraction for actual conversation about do we have an efficient government? Do we have a skilled workforce that understands? Because what you don't want is to become the bottleneck of approval. We're continuing that FDA example, because as opposed to 50 years ago, now the biotech companies and others have options. They can go to other countries, so Europe and Australia and New Zealand, to get their drugs approved. But then there's also, we have China, we have other countries that can actually get ahead of the regulatory processes and lead us, which has never happened prior, but that is a true and present risk right now. So at the end of the day, I think we have to look at our workforce in federal government as well to see, are we up to par with the skill set and training?
And you've talked about a lot about the advantages of AI and drug discovery. Does it introduce any new risks?
I think there's always going to be risks. So there's nothing is risk-free. I think the challenge becomes more that how do we get AI adaptation that is free of as much biases and hallucinations and other aspects. So that's where it becomes important. We're going to have multiple iterations of AI. I think we're going to get to a point where we are reliably able to substitute animal testing, for instance, as a norm for drug discovery. Animal testing will still need to happen, but for a much smaller cohort as opposed to regular way of doing business. So I think some of these risks will phase itself out, but what is very clear is what we're seeing today, as we've been seeing for the last 50 to 70 years, is probably not going to stay. We're probably going to need to have different mechanisms of molecular discovery, multi-mechanistic disease solutions, as well as the timing and cost of it.
And in terms of R&D, we've seen this administration, get into these fights with universities, try to cut funding, obviously doing more to restrict foreign visas for students. Long term, what do you think this administration's policies, what kind of impact is that going to have on R&D long term?
I think what the American people are really going to appreciate is having smarter government, not one that is at odds and fight with everybody and so-called. I think one of the ways to do it, get to that smart government aspect is, for instance, if there's continuous funding for molecules at academia that does not succeed, is not the way to go. But technology is here today. If you've got molecules in the university setting, and technology will tell you ahead of time whether this molecule is likely to succeed or not, I think making that contingent upon grant making becomes important. So there are important federal policies that can be adapted today that will actually not only save billions of dollars of federal taxpayer money, but actually be smarter government and sort of expedite the amount of discovery that happens, especially for not only common diseases that we haven't had for dementia and others, but also for rare and ultra-rare diseases. I mean, we're working with solutions for ALS, for example, right now. So there are so many people across the country that suffer from rare and ultra-rare diseases that cannot find solutions because it's not a market mover. Those investments. This will allow that to happen. So I think we start to shift in that way.
And obviously the pharmaceutical supply chain is global. We're dependent on other countries for a lot of drugs. When you think about the prospect of some kind of conflict, involving China, whether that's, in the South China Sea or over Taiwan, something like that, I mean, what's the worst case scenario we could be looking at in terms of the pharmaceutical supply chain?
Thanks, Morgan. I know we just had a conversation with the previous speaker on that. I will tell you that if that conflict, which is the number one threat to the United States, would happen, there's likelihood that there will be more people devoid of medications on the streets and sort of getting complicated and dying than potentially soldiers in the battlefield. The reason for it is that the key source materials, or KSM as they're called, come from very few countries. That includes China, India, Brazil, and Israel. And from there we make APIs, the active pharmaceutical ingredients. From there we make drugs. So it will be like having car factories without car parts. So all of our manufacturing is put to no use if you don't have the raw materials from it. So it is very important to think about, from a national security standpoint, a strategy that nearshores, even to the American continent, the ability to have the raw materials available, because today we have such a high burden of disease, from heart disease to diabetes to others, and we saw the consequence of that during the COVID pandemic. But that's a clear national security threat to us.
Right. Well, thank you so much for your time. I really appreciate it.
Thank you so much.
Thank you for attending today's event, and a special thanks to our partners, West Health and Gallup. We hope to see you at our next event.